All right, yeah, there's our disclosure. So this is some general medical advice, but it's not specific to your medical condition. So if you need additional advice, contact your or speak with your provider or come see one of us to get to additional recommendations that are specific to you. Next slide. So before we start, I just wanted to give you an introduction on both of us. So I'm going to be talking first, and so a little bit about me. So my name's Sean Matsuwaka. My specialty is called Physical Medicine and Rehabilitation, or PM&R, or also physiatry. And if you haven't heard of it, it's a specialty that focuses on improving patients' functions. And you may be more familiar with some of the other things that I do. So I did a fellowship in New York, specializing in sports medicine and interventional spine care. I also have a certification in musculoskeletal ultrasound, and I work primarily at the UW Sports Medicine Clinic in Ballard. I spend 4 days a week there, and the other 1 day a week I'm at the Meridian Pavilion Spine Center up near Northwest Hospital. And then a little bit about Maggie. She'll be talking to you during the second half of the talk. So she's a board certified physical therapist with additional board certification as a sports clinical specialist and a orthopedic clinical specialist, which just means she can provide excellent musculoskeletal care for athletes and non-athletes of all different ages. And she's primarily located at the UW Medicine Sports Medicine Clinic at Husky Stadium. So just a little outline on what we're going to be talking about today. So for the first half, I'm going to be talking to you all about back pain and how common it is, what are common causes that can result in back pain, and what are risk factors, and then give you some more general advice about when you should talk to a doctor, what a typical medical evaluation looks like, and then I'm going to talk to you more about the medical treatments, and I'll leave the physical therapy part of the talk to Maggie. So in her second half of the talk, she's going to be talking to you about her typical evaluation, how she looks at your gait, your kinetic chain, and strength. She's going to be talking to you about different types of treatments, including exercises, stretches, movement training, and then she'll touch on some prevention strategies as well, including strengthening, stretching, cross-training, and load management. So first off, to put things in perspective, so how common is low back pain in runners? So just in general, in the general population, back pain is extremely common. It's one of the top 5 most common causes of back pain. It's one of the top 5 most common presentations of patients to their primary care doctor. And nearly everybody experiences back pain at some point in their life. So if you ask anyone within the last year, up to 45% of people have experienced some type of back pain within the last year. And studies that have surveyed runners at any one point in time have found that up to 20% of runners have back pain for some reason or another at that point in time. So regarding back injuries in general and how common they are in runners, they're not the most common running related injury. There are other injuries that are more common in the lower extremities, like knee and ankle injuries. However, I mean, with back pain being so common and prevalent in the general population, it's very relevant, and I think it could affect you at some point or another in the future. And back pain can be both acute or chronic, and somewhere in between as well, acute on chronic. I see all back pain that has been there for years. Other people with back pain for a day or two. It's just very variable. So just wanted to touch real briefly on the anatomy of the low back. So as you can see here in the pictures, there are a lot of superficially, there are a lot of different muscles and tendons and fascia that come into play that can cause pain. And deep to those muscles, there are other things like the bones, the joints, the discs that act as shock absorbers between the vertebrae, and the nerves that come out on the sides of the vertebrae in what are called the foramen. Those nerves can get injured and pinched as well and cause problems. So you may be asking why is your back hurting from running? So there are a lot of potential different causes. One being an acute injury where you fall or twist or pull your back in a certain way. You may also have back pain from a flare-up of a previous injury that you've had a long time ago. There can be other things like overuse, where you've had a really quick change in the amount of activity or amount of activity you've done in a short period of time. Or there could just be some gradual wear and tear over the course of your training or over your years, where at some point your back just starts hurting. And underlying all of that, it's very common for people to have weakness within their core muscles that can result in back injuries, because with poor core strength, you can have abnormal loads on the spine, and this can lead to injury. And I just wanted to also emphasize that with core weakness, it can also cause injuries to other parts of your body, including things like your hip, your knee, your ankle, or Achilles. So it's a very important structure that we'll talk more about. Other things that can happen is, I mean, your back may start hurting randomly, kind of from other non-running related events. I hear a lot of people that say they just wake up one day and their back's hurting. So it's not always directly related to running. But beneath all of that, there may be anatomical problems that I'll go into. And then importantly, there are other potential biopsychosocial factors that I'll touch on as well that can also contribute to back pain. There are other potential risk factors that can contribute to back pain. There are not a whole lot of studies that have looked into back pain that happens in runners, but some of the studies that I have found a few number of risk factors. Some of them being one, being a runner for over 6 years, having a body mass index greater than 24, which is a measure of your weight to your height ratio. It's more common in taller runners, more common in people that have limited or tight muscles in their hips, hamstrings, and spine, and then more common in people that have leg length differences. However, I also want to emphasize that in all of these studies, they've looked at runners, and they've notably said that running longer distances does not actually create a higher risk for back pain, and that a lot of these reported physical and training related risk factors are actually treatable and modifiable with intervention. So you're not totally stuck with them, and there's things you can do to reduce the risk. So before I move forward, I also want to touch on some of these biopsychosocial factors. So what's really important to note, and a lot of research related to back pain has showed that not all causes of back pain are purely anatomical or injuries to anatomical structures, but there are a lot of other factors that can come into play that can make back pain worse, can prolong it, and can lead to even chronic back pain. And the reason for that is because pain is not black and white. Pain is an experience that's different for everybody, and it really depends on how the nervous system and each person's mind interprets these painful inputs from their environment. And there's a lot of factors that can affect that environment. There's shown to be a lot of relationships between just the anatomical problems, the biomechanics and how you move, again, how the nervous system and the brain processes that information, and then how other psychological issues can come into play and make pain worse, such as having bad experiences with pain in the past, or having significant fear of pain and avoiding experiencing pain again. So unfortunately, some people can develop chronic pain, which is typically an issue with how the brain processes all of these painful inputs. And the thought is that the brain incorrectly interprets pain as being very harmful, and it tries to protect the body by giving off by telling the body that these things are bad and hurting when they actually are not harmful for you. So that picture on the right there shows kind of the intersection of how all of these factors come into play. So there are biological factors, like I said, the physiology, the anatomy, the health of your tissues, and those come into play and interact with the psychological things like your mental health, your mood, your emotions, your prior experiences with pain. And then the sociological side of things also comes into play and factors in terms of the relationships you've had with other people, the social support systems that are in place for you, and all of those together come together and can cause or worsen back pain. So going back to the anatomical things, with that being said, I just wanted to briefly touch on various things that can cause back pain within your body. So from a more starting with the muscle and the nerve, in terms of the muscles, you can have imbalances between your strength and flexibility. You can have acute strains of the muscle. You can have overuse related injuries from if the muscles are not strong enough or the core is not strong. And then you can have nerve injury where the nerve gets compressed, which is commonly called sciatica. Looking at the bones and the discs, you can have discs that can, in the back, you have discs, and within them they have a jelly-like solution that can herniate and can push on the nerves and cause that sciatica. You can have tears in the discs that can hurt. The discs can become degenerated or desiccated, where they get less less, they lose some of the fluid within them and then become less tall and less compliant. You can have acute fractures, arthritis, shifts in the bone and how they're aligned. But note in red that a lot of these findings can be very common in people, especially as they get older, but are not always symptomatic. So you'll have to kind of take all of these findings with a grain of salt, which I'll touch upon in just a second. And then the last thing that we as providers think about are some of these other really rare causes of back pain, like infection, bone marrow disease, inflammatory conditions, or cancer. But those are really not too common, but we still have to be aware of them and think about them when we see all of our patients. So some scary medical terminology. I mean, I hear a lot from different patients in terms of what they've been told they have in the past. So it's really important to keep in mind that not everything that you see or hear is really harmful or hurting you, because I've had people come in and tell me that their back's degenerating, they have multiple disc bulges, they have tears in their discs, their spine is unstable and crooked and out of alignment. People have told them they've had broken backs, all types of things. And so, sometimes just giving people these labels or talking about these things makes things worse rather than better, because like I said, not all of these things actually always cause problems. And other people come and tell me that they're hearing cracking and popping in their back and their knees and other joints. But again, I mean, as long as it's not painful when you hear that cracking or popping, it's not always a bad thing. I tell people a lot of the time that sometimes this cracking, popping is actually just air moving through the joints as they move them. So it's usually not anything to worry about if it's not hurting. And this is just a disclaimer I wanted to share. So, like I said, a lot of things that you see on imaging, and MRI is a very common form of imaging for the back. There are a lot of things that you can see that don't always cause symptoms. So, the UW system and the radiologist have put this a disclaimer at the end of any type of spinal MRI that they perform within our system. So I'm just going to read it for you. So it says, the following findings are so common in normal, pain-free volunteers that while we report the presence, they must be interpreted with caution and in the context of the clinical situation. Among people over the age of 60 who do not have back pain, an MRI will find that 9 out of 10 of them have disc degeneration or disc signal loss. 8 out of 10 of them have disc height loss or bulging. 4 out of 10 of them have an annular fissure, a disc protrusion, or facet degeneration. So basically, this just says that we do MRIs of people's backs, but you really have to correlate what you see with what you're experiencing and what your examination and your symptoms are, because as you get older, I mean, even I've seen people even in their 20s, but the older you get, the more of these things you may see. And like I said, they're not always painful, they're not always bad and harmful. They may just be there. I tell people sometimes it's part of getting older. It's like getting gray hair or getting wrinkles. It's just you get them as you age. So we treat them if they're symptomatic, but if they're not symptomatic, you just leave them alone. All right. So you may be wondering, does running form and back pain, are they related? So one study showed that runners who have had back pain did develop a change in their running form, or they called it a guarded gait, which meant that they had reduced motion in their trunk and their pelvis and hips when they're running, and that this changed with just even one episode of back pain. And they saw that people that had a history of back pain did have differences in how they ran compared to those without back pain, even in those people that weren't having back pain within the last 6 months. So yes, there is a change in form when you run, but I just want to point out that the study never said that there isn't like an ideal way to run. There's no perfect way that you can run to prevent back pain. I mean, there's ways that you can improve your gait to look normal, but there's no exact way that you need to run to prevent injury. And I just wanted to give you some background here about when you should see a doctor, because a lot of people ask me about this. So there are certain things called red flags, which are symptoms or signs that we really worry about as doctors. So if someone comes and tells me they have like urinary or stool incontinence, like severe unrelenting pain, or they have any like systemic symptoms like fevers, chills, night sweats, or weight loss, then those can be concerning, and those may indicate that we need to do a further workup to make sure nothing else more serious is going on. The other times where that can be somewhat concerning are if you're noticing pain that's radiating down your leg, noticing weakness in your leg or your foot, new numbness or tingling, that can all indicate that there may be some type of nerve problem. It's also reasonable to see a doctor if you've had pain for several months, despite doing conservative treatments like physical therapy or relative rest. And of course, it's reasonable to see a doctor when you're worried or concerned and unsure if this is going to be a long-term or serious problem or not. Then definitely go see a doctor. So just to give you a little background about what a typical medical evaluation looks like with me. So initially, we would talk, and I'll do my best to understand your history. So get a good sense of how long the symptoms have been going on for, where you're feeling them, what makes it worse, what makes it better. And then I would do a very detailed examination, which involves watching you walk, watching you move, pushing on various, or touching various areas to see if they're painful, doing a very detailed neurologic examination where I look at the strength, sensation, and reflexes in your leg, and then doing some higher functioning things like testing your core strength. So things like what's called a single leg squat, testing the strength that you have in your hips, all to give me a sense of what's going on. So in terms of imaging, a lot of people come to me and they want imaging. So it's important to note that imaging is not always necessary acutely when you have acute pain with, let's say, a week or two of back pain. It's mainly necessary for people that have had those red flags that I mentioned, have some type of serious recent trauma, like a big car accident, have neurologic changes like in their legs with weakness or numbness or tingling, or if they've had symptoms for more than 3 months. And the different types of modalities that we usually look at the spine with are either X-ray, MRI, or CT scan. So X-ray is a good way we can screen things, look to see if there's any fractures, any big shifts in the bones that are misaligned, any big change in the discs in terms of how tall they are. And then the MRI is truly the best way to look at the spine. So it gives a good picture of the bones, the discs, the nerves. But it's not always necessarily needed, like I said, unless you're experiencing pain that's radiating or any of those red flags. And then CT scan is, I don't commonly order these, but they're more to look at the bones more in depth if say the x-rays look normal, but I'm worried about some type of fracture, or say there's a contraindication to getting an MRI. So the main question I ask about imaging when I order it is, why are we ordering this? Is it really necessary? And that's kind of what I explain to patients. So if we order imaging, it's to do something about it. It's if we're considering doing some type of procedure or injection. It's to consider for referring you to surgery, or if it's to work you up for something more serious like cancer or something like that. So if it's not going to change the management and we're still going to continue treating you with physical therapy or just conservative measures, then it may not be necessary. So just some important points that I wanted to bring up about back pain in runners. One is that many studies have shown that running does not often make things worse when you have back pain. That's not to say that you should keep running 10 miles when your back's hurting, but you may need to scale back, kind of listen to your body and see how it feels the next day after you run, and tone it back if it's hurting too much. And then in terms of ramp up, you can ramp up slowly and get back to running. I tell people 10% at a time in terms of the duration, the distance, the frequency, that type of thing. The next point I want to make is that running does not put you at a higher risk for back pain for things like spine degeneration, for disc degeneration or herniations compared to any other sport or activities. In fact, many studies have shown that physical and aerobic activities are actually protective against low back pain. And also back pain and back problems in runners are typically chronic or episodic or episodes of pain rather than like an acute injury from like a fall or trauma to the back or necessarily an injury to the muscles. It can be something that's been ongoing for a long time that just flared up again. All right, next slide. And then lastly, I wanted to talk about some of the medical treatments that are involved for back pain beyond physical therapy. So number one is education. So I try to do my best to spend a lot of time with my patients, explaining to them what I think is going on, whether I think it's concerning or not, and what I think can improve with conservative measures, such as like rest, modifying your activities, physical therapy, versus what is actually more concerning and could get worse and would need more urgent intervention. And I try to explain to people that the natural history of back pain, because the natural history is that sometimes all your body needs is time, and a brief period of relative rest and reduced activity can actually lead to the back pain resolving. And in the majority of cases, it does. the one thing that we do point out is that bed rest is not good for you. So you shouldn't just lie in bed and do nothing the whole day, because that leads to deconditioning and more weakness in the core. And yeah, many studies have shown that we should continue to be somewhat active, mobilize, and do gentle activity, day-to-day activity as soon as you can. And then other things you can do are using topical creams. Everyone's a little different, so everyone responds to different creams differently, but typically I just recommend different over-the-counter medications like Bengay, Icy Hot, Biofreeze, that type of thing. And then heat and ice can also do wonders too for acute back pain. Next slide. So briefly, I just wanted to talk about exercise and physical therapy. Um, uh, so I'm going to leave most of it to Maggie, but exercise, physical therapy can obviously be very, very helpful for back pain. So there have been many studies that have shown core strengthening can help people to recover quickly from injuries, and to also to prevent future injury by strengthening and stabilizing the spine and preventing excessive forces on the actual anatomy beneath the muscles. Core strengthening has also been shown to actually improve running efficiency and performance as well. And I like to promote active treatments as opposed to passive treatments, which means the patient or the athlete is actively involved doing exercises on their own, as opposed to just having someone or somebody do things to that person, like massaging them or other types of modalities. And this picture below, I just wanted to incorporate in terms of one of my mentors described this to me in terms of the approach that we usually take to rehab. So after assessing the patient, we put them into one of these four categories here, either stiff, mobile, weak, or strong. So for example, looking at the bottom left box there, if someone's really mobile and flexible but weak, then the focus should be on the the plus, which is strengthening. So yeah, weak and mobile, they should focus on strengthening. But if they're very stiff and strong, so say that upper right box, then they already have the strength in place, so the focus needs to be more on strengthening, on stretching, sorry. And then if the other two boxes are kind of a combination of those two things. All right, next slide. And then other things that you can do for back pain. So over-the-counter medications can be helpful, and sometimes they're enough. So typically I recommend Tylenol or acetaminophen, as long as you don't have any liver problems. The alternative would be anti-inflammatory drugs, or also called NSAIDs, like ibuprofen and naproxen. I tend to, these can be very helpful, but you have to be careful with them if you're taking them long term, because it can cause kidney problems, heart problems, or stomach problems if you take them for long periods or at high doses. There are other medications that we sometimes prescribe for nerve pain, like gabapentin. Sometimes you may have heard people receiving muscle relaxers, which I think are okay for short periods of time. What I think they do more so than relax the muscles is actually just sedate you. So they help people to sleep who are having lots of pain who can't sleep. And then in terms of narcotics, we try to avoid these if we can, because many studies have shown they're not much more effective than just over-the-counter medications, and they have a lot higher risk for addiction or tolerance or side effects too. And in terms of injections, a lot of people come to me wanting injections, but typically injections are more beneficial for people that have that nerve pain or sciatica, or people that have had chronic pain from arthritis. I mean, sometimes I do trigger point injections, which are into the muscle to help the muscles relax, but that's typically a short-term solution. I don't commonly recommend doing that frequently. And then surgery, of course, can be has certain indications for things like red flags or weakness in your legs, but it's not something that we commonly jump to initially. Next slide. And then lastly, I wanted to touch on the other things. So as we talked about before, biopsychosocial factors can come into play. So addressing all of these psychological and social factors can be very, very important as well. So treating life stressors, having someone like a therapist or a psychiatrist or psychologist talk to athletes or patients about improving their mood, working on their social relationships, and then improving sleep, because sleep is very important for recovery and for improving pain. And just briefly, I'll touch on alternative treatments. I'm sure many of you have tried things like massage, chiropractor, and acupuncture. And I think these can be helpful for acute pain, but just remember that they are passive treatments where they're doing things to you, so you become dependent on them. And I think it's really important to find a good one, because they are alternative medicines. They aren't evidence-based, and you have to be very careful about what some of them tell you. And because if they tell you the wrong thing, it can cause worry and stress, and it may not always be accurate. And don't get trapped into someone who's trying to get you to come for 20 visits and charging you a huge amount of money to do that, because sometimes those people are just out to make money. And then lastly, I just wanted to say that there's been studies that have looked at specific footwear to see if footwear can alter and prevent lower extremity injuries or back pain. There isn't any specific footwear that's shown to help be totally beneficial and help everybody, because everyone's a little bit different. So yeah, there's nothing that I would definitively recommend in terms of shoes or other orthotics. And the last thing is weight loss. So if you or someone's overweight, I mean, it never hurts to lose weight, and that just puts less pressure on the spine and the spinal elements as well. All right, so that's all I have to say. So I'm going to turn it over to Maggie now.
All right, thank you, Dr. Matsuwaka. I am Maggie Catlin. As discussed earlier, I'm a physical therapist who specializes in sports and orthopedics at Husky Stadium. Next slide. Before we get into the details, there is one concept that underlies much of the physical evaluation and treatment. Many people have heard of Isaac Newton, whether it be the story of the apple falling from the tree, or maybe you even remember his 3 laws of motions from physics class. I wanted to take a moment to review the 3rd rule. Next slide. For every action in nature, there is an equal and opposite reaction. In terms of the human body, this means every time you press against the ground to propel yourself forward, the ground pushes back on you in the equal amount. In physical therapy, we call this ground reaction force. If the static structures, such as your bones and your joints, and the dynamic structures, mainly being muscles, of your body are not strong enough to withstand these forces, you may develop pain. If you absorb this reaction force through your muscles and tendons, you can use their spring-like qualities to transfer that energy into forward motion. In other words, you will be more efficient. Next slide. As a physical therapist, I'm going to look to answer 2 main questions. First, what structure or tissue is undergoing more forces than it can tolerate? And second, how can we better distribute those forces or build the irritated tissue's tolerance? I want to take just a moment to reflect on my use of the word tolerance. Notice I did not use the word injury or damage. This is because the body responds as pain to a multitude of factors, and pain does not always equate to damage, as previously discussed. Physical forces are just one of the factors that contribute to the experience of pain. Next slide. When we look at the human skeleton, we can notice that there is a section of the center that has relatively little bony stability. Now, this is good. It allows us a great deal of mobility and function, but that also means that this section depends on muscles to provide support. Next slide. The core muscles create that support. In the front, you have your transverse abdominis. Now, we label this as the front, but is actually more of a corset and reaches around the trunk on the front and the sides. On the back side, we have the deep spinal muscles called the multifidus. On the top is the diaphragm, and on the bottom, the pelvic floor. As these muscles contract, they create pressure inside the core that gives it rigidity and stability. These muscles are so important that the transverse abdominis has been shown to contract before any arm or leg movement in order to give the muscles a stable base to pull from. Next slide. What happens if you don't have a stable base? Your body has to work harder. It is inefficient. I like to compare it to a tug-of-war contest. As we pull, we would like our feet to be on a sturdy, dry surface. Click. But what if your feet were on a muddy surface? How much harder would you have to work to create the same amount of force or pull on the rope? This relates back to the increased efficiency we see in running if we perform core strengthening and training. Next slide. When you have pain with running, this also causes patterns to change. The muscles around the area of pain contract to try to protect the segment from moving. This will cause you to move the whole segment of the body at one time. Think of what a person looks like when they are limping due to an injured ankle. They move the whole leg as one piece instead of multiple joints. People also move much more slowly. This allows them to coordinate the guarded movement as well as decrease ground reaction forces moving through the body. Overall, the movement becomes much more inefficient. It takes more energy to move the body over less space. Next slide. So how can we improve the health of the spine and core with running? In physical therapy, we approach this with 4 main techniques. First, reduce the pain. Second, improve imbalances in strength and mobility. Third, improve movement inefficiencies. And finally, improve the individual's independence with their self-management of flare-ups, as back pain is likely to recur, just as other joints in your body get aches and pains. But if you know what to do, it doesn't need to be scary. Next slide. I'm going to highlight a few pieces of information we want to know for physical therapy treatment. First, how did it start? Was it sudden and traumatic, or did it have a slow start with no notable injury? I also want to understand how long it has been occurring. The longer the period of time and more intense the symptoms, the more pronounced the guarding and changes to movement coordination will be. There will also be increased sensitivity of the tissues, causing higher levels of pain. Finally, I would want to know what motions make it better or worse. While identifying the exact tissue causing pain is difficult, with many cases of back pain, patients improve their pain faster when the motions that relieve their pain are performed multiple times a day in the short term. Next slide. As we move through the physical exam, we are going to try to recreate and then alleviate the symptoms. This allows us to give the patient direction and ways to improve their pain on their own. Typically, there is a preference for either flexion or extension. Next, we will look at muscle length or tightness. Some common areas of tight muscles are the hip flexors and hamstrings. We will measure the strength of the muscles of the stomach, back, hips, and legs. As we develop a hypothesis of what tissue is causing pain or inefficient movements, we will touch various areas of the back, core, and hips to see what is irritated and painful. Next slide. The next thing we are going to look at is how you move. We will perform a video analysis from both the side and the back, looking for various compensation patterns. Next slide. The first thing we will look at is tibial inclination angle. You can see this in the red line. Ideally, your shin will be almost perpendicular to the floor when your heel hits the ground. Next slide. The next thing I will look at is forward lean angle. We want to see a small forward lean through the body. This allows you to maximize forward momentum. Next slide. The third element will be hip extension. If the deep abdominal or back muscles are not working optimally, it will cause the hip flexors to work to stabilize the spine. This will lead to decreased hip extension and forward tugging on the pelvis and spine. If you observe the runner in this picture, he is getting excellent hip extension. For those of you who don't know who this is, he is one of the fastest distance runners in the world. Next slide. The fourth element is spinal posture. Is the pelvis tipped forward and the back extended, or is the pelvis tilted backward and the back is flat? We want to see just a little extension in the spine. With a little extension, the spine can move like a spring. The individual on the left, the blue shirt, has a flat spine. If you look at the individual on the right, they have an arched spine. This would be considered overextended. The individual in the middle would be considered neutral or a slightly extended spine. This is the ideal posture. Next slide. The last element I will look at from the side is vertical displacement. How much do you move up and down? The more you move up and down, the more energy for forward motion you have lost. Next slide. From the back, I'm first going to look at thoracic or upper back rotation. This gives me a good clue as to how well the core is functioning. The individual in the blue on the left is getting good rotation, while the individual in the gray and orange on the right is not. Next slide. The next thing I will look at is if the hip is dropping down. In this picture, the individual in the white and yellow on the left has minimal hip drop, while the individual next to them in the black and blue has a large hip drop. Next slide. Finally, I will look at how much the arch is collapsing or the foot is pronating. It is a bit harder to see in this picture, but the individual in the blue shoe on the left is getting more arch drop or pronation than the one on the right in the orange shoes. Next slide. Next, I'm going to break down some running movements into simpler versions. This gives me a better idea of strength or mobility imbalances that may be driving the movement pattern. This could include single and double leg squats, lunges with rotation, single leg jumps, or single leg heel raises, among many others. Next slide. Once I have an idea of what the movement looks like and what could be involved, I will test the strength through the core, hips, and legs to test my hypothesis. Some of the muscles we look at are the transverse abdominis, multifidus, quadratus lumborum, and obliques, the hip rotators and abductors, and the quads, hamstrings, and calves. On the picture on the right, I'm using a crane scale and an iPad to measure hamstring force production. Next slide. I will also assess if any muscles are too tight and impeding movements. Some of the most common are the latissimus dorsi, shown in the picture on the far right, the back extensors, shown in the top picture, the hamstrings, shown in the bottom picture, as well as the hip flexors and calves. Next slide. One common presentation we see is tight hip flexors, overstretched and weak gluteal muscles, decreased strength through the abdominals, and tight back muscles. This is typically due to prolonged sitting at work. Next slide. Now let's revisit our treatment slide. Once we have figured out what movements cause or reduce pain, what muscles are too tight or weak, and how this is affecting movement, we can begin organizing a plan to address the relevant pieces. Next slide. In reducing pain, we will look to direct the individual into movements in relieving directions. If there is pain with forward bending, we will do an activity such as a prone press up on the left. If there is pain with bending backwards, we may do a knee hug in the center or lie with the feet up on a couch or a chair. Typically, some muscles are irritated and contributing to pain. We can use a lacrosse ball or a foam roller to relieve the tensions in the muscles. We may also do massage in session to reduce the pain. We want to encourage the individual to continue moving. Walking in particular is typically very helpful in improving lower back pain. Finally, there is emerging research on incorporating 528 Hz music or binaural beats into the day. Binaural beats are sounds played through earphones that send different frequency through each side. There are plentiful playlists on Spotify and YouTube of both of these. This can be performed during any activity or even when sleeping and has been shown to reduce pain levels. Next slide. In improving strength, we're going to focus on the four main core muscles of the diaphragm, multifidus, transverse abdominis, and pelvic floor. We will layer that with strengthening for the obliques, back extensors, hips, and legs, as indicated. Next slide. The first step in core training is finding the deep core muscles in the first place. I want everybody to take your hands and place them on your sides. You should feel a hard hip bone we call the ilium. As you walk forward from that bone, you will fall off hard bone onto the softer abdomen. I want you to place your fingers just off the bone on the soft abdomen. Now, pull your belly button in towards your spine and up towards your rib cage. You can also think about pulling your belly away from your fingertips. Pull a little harder and a little harder. Did you feel anything become more firm under your fingertips? Try again. Pull in and a little more and a little more. Did you feel it? If you did, that is your transverse abdominis contracting. This muscle should turn on and fire before any other movement in your body. It should be firing during every exercise you perform to strengthen your abdominal and back muscles. Next slide. Next slide. Some of you may have felt like you had to hold your breath to perform this maneuver. It may not make sense that you would try to do this while doing any strenuous or workout activities. You need to breathe. What you are experiencing is what we call global recruitment. Simply put, when your body isn't used to firing a muscle, the pathway isn't very efficient and the body fires other muscles that work to help that muscle. In terms of your transverse abdominis, this is your diaphragm. If your diaphragm is helping, you won't feel like you can breathe at the same time. Keep practicing with short holds. As your nerve pathway becomes more efficient, you will be able to contract your transverse abdominis and breathe at the same time. Next slide. This slide shows just 4 of the common exercises we would use to strengthen and improve the firing pattern of the transverse abdominis. As we discussed earlier, the first step is just finding the muscle. Once an individual is able to do this and breathe without difficulty, we progress to performing the maneuver and march or extend the legs. A common progression from there might be to have the core support the spine as both legs are off the ground, as you can see in step 3. Then off the ground and moving in the dead bug exercise shown in step 4. Next slide. Now let's talk about the back side of the core. This is the multifidus. These are very small muscles that run between 2 to 4 lumbar segments. It connects to the transverse abdominis via the core fascia. Weakness in this muscle is associated with lower back pain. Next slide. So what are some exercises that we can do to strengthen the multifidus? We want to work the spinal extensor muscles with slight rotational pull. At first, it is easiest, especially if someone has pain, to perform it in a neutral spine. The multifidus doesn't have as many neural feedback fibers as other muscles. So while you may feel some tightening in the back region, usually you will not feel a burning as you would with other muscles when they get fatigued. As the multifidus fatigues, you will typically just feel more difficulty coordinating movement. In clinic, we start with the simple exercise of just lifting the knee from the ground, as you see in step 1. I have patients focus on keeping the weight through their arms even. It is important to draw the belly button in and activate the transverse abdominis at the same time, as this improves the recruitment of the multifidus. After this, we will progress to just arm and leg lifts and then arm and leg lifts as in step 2. You will notice we move the arms and legs in a reciprocal pattern similar to running. From there, you can progress to single leg bridge and then an RDL. Notice we are progressing from simple exercises on the floor to more functional movement patterns similar to running. Next slide. As you improve your use of and control of your transverse abdominis and multifidus, it is important to practice using them with movement patterns more similar to running and eventually with running. An exercise we may start with would be engaging the deep abdominals and holding a squat while sliding a leg to the side in a diagonal or backwards, such as in step 1 above. A second step might be to add a rotational component, such as in a curtsy squat. We may then progress to a lunge, practicing utilizing the core to provide stability and rotational power. Finally, we will move to a single leg movement with resisted rotation, utilizing the core and back muscles to provide control of rotation and forward flexion in a pattern similar to running. Next slide. As you are able to perform more complex patterns, maintaining control through the core muscles, we will progress that to running itself, typically focusing on internal control of muscles, such as pull from your hips. Doesn't work as well as external cues, such as increasing cadence to a metronome, trying to pull the ground under you as you run, or moving alternate shoulders forward as you run. Depending on the injury, we may also try to change the foot strike. This can be a short-term method to reduce loading to sensitive tissue, but there is no research to suggest one foot strike method as superior for injury prevention. Next slide. Next, I will talk about injury prevention. Many of these tenets are similar to how we would treat a painful spine. Next slide. The first component is stretching. Research has found that performing moving or dynamic stretches prior to activity reduces injury and improves performance. Meanwhile, static stretches of greater than 30 seconds can actually decrease performance and increase the risk of injury. If a muscle has been deemed too short, it is important to perform sustained hold stretching greater than 30 seconds to improve its length. However, this should be performed after activity, or at least an hour before exertional activity. The top 3 pictures show some of the most common dynamic stretches that are easy to perform before running. This includes a walking lunge with a reach backwards, walking front kicks, and walking butt kickers. The bottom 3 pictures show some common static stretches that I prescribe that are best done after or long before running. Next slide. As discussed under the treatment section, strength is one of the most important factors in spine health and injury prevention. Strengthening should be performed for a minimum of 30 minutes 3 times a week in distance runners in order to facilitate the recovery of tissue. This is because running induces a high amount of low load stress on the body. This causes tissues to slowly break down with no hormonal stimulus to rebuild. Strengthening exercises provide the cue to the body to rebuild and strengthen our tissues. Next slide. Many individuals do not like to go to the gym and do strengthening workouts on their own. I encourage these individuals to integrate cross-training classes such as HIIT workouts, Pilates, or barre into their routines. For those of you whose bodies traditionally have not handled the jarring force of the ground with running, water jogging, water jogging, or the elliptical can be ways to improve fitness levels with less stress to joints and cartilage. Next slide. Last but certainly not least is load management. If there has been one factor that has been consistently correlated with injury, it is peaks in load. Wolff's Law states that the body adapts to imposed demands. However, it can only adapt so fast. If asked to adapt too quickly, tissue will break down and injury will occur. In sports medicine, we try to keep the acute to chronic workload ratio less than 10%, certainly less than 20%. As you move from a 10 to 20% plus increase in 1 week, the risk of injury in the next month grows exponentially. That's correct. The risk of injury isn't just for that day or week, it can continue for a full month. Now, in sports medicine, we compare the current week's load to a weighted average from the prior month. This is a complicated equation. So my guide to most of you is to keep it under 5 to 10% a week. The simplest way to do this is to follow a running plan. The plans by Higdon and Galloway, among others, are some good popular plans that are easy to follow. Finally, plan for periods of the year with decreased running volume and increased strength training or cross training to allow tissues to recover and build integrity. In summary, the most important stabilizers of the core are the transverse abdominis and multifidus. Activate the transverse abdominis by pulling your belly button into your spine. Improving core strength and movement patterns will improve pain and the health of the spine, as well as improve your running efficiency and performance. Physical therapists are movement specialists that can help you identify the muscles and patterns you individually should devote time to. Next slide. These are just some references that we have in the next 2 slides. You can do the next slide. And then finally, any questions?